a board-certified obstetrician and gynecologist at Baptist Health, South Florida. He received his medical training at the University of the West Indies Medical School in Kingston, Jamaica, and he completed his residency in obstetrics and gynecology at the University of Alberta, Canada, followed by a fellowship in maternal fetal medicine and surgical ICU at the University of Miami Jackson Memorial Hospital in Miami, Florida. Dr. Lai served as an assistant professor of obstetrics and gynecology for the University of Miami, and later as an assistant professor of pediatrics. In addition, he was a medical director of labor and delivery for Jackson Memorial Hospital, University of Miami. Dr. Lai has been published widely in peer-reviewed journals, has been an author of various books and chapters, and has done several presentations nationally and internationally in obstetrics and gynecology, and of course in high-risk pregnancies. He's a recipient of the George Paff Faculty Teaching Awards from the University of Miami Miller School of Medicine, and a member of the Alpha Omega Alpha Honor Medical Society, as well as a member of the Society of Perinatal Obstetricians and the College of Physicians and Surgeons of Canada, among others. Please, let's give a warm welcome to Dr. Anthony Lai. Dr. Lai, what a pleasure having you with us today. Thank you so much for accepting our invitation. The floor is yours.
Thank you, Dr. Hakim. Thank you for your warm welcome. Again, it's my pleasure to give this talk. It's actually my favorite area of obstetrics currently, and you'll see why as I go through the talk. Because the solution is often simple, but the problem great and heartbreaking. So let me go directly into the talk. So it's looking at some new aspect of a very old subject. So I'm going to review the diagnosis, how we make the diagnosis currently. I'm going to discuss some management controversies and very recent addition and recommendation by the American College of Obstetrics and Gynecology, and touch on some of the surgical aspects and certainly some of the new things that are being done at Baptist Hospital regarding this old subject, shall we say. So when we say an old subject, well, this term cervical insufficiency has been around for over 100 years and was first introduced as a title in 1865 in the British journal Lancet. So again, a very old subject indeed. Well, it took a long time to come to any kind of solution to the problem, and it was 100 years later when we figured out a surgical solution to the problem of the incompetent cervix. So I think everybody is familiar with the name Scherotka, Professor Scherotka from Bombay, or at least formerly city known as Bombay, now Dubai. And 2 years later, from Australia, Dr. Ian MacDonald introduced a similar technique, but in fact has now become the more popular technique just because of its simplicity. I emphasize here that back then, of course, they hadn't figured out how to study it in terms of the effectiveness, and it was their own patients with their bad obstetrical history that served as the control for themselves. And of course, they had many successes with their patients. So the procedure, again, just to summarize the procedure, the Scherotka procedure, again, many are familiar with it, or certainly seen some of the older physicians do it. And the difference, of course, is that there is a dissection anteriorly and posteriorly to mobilize the bladder anteriorly and the rectum away from the cervix so they could place the cerclage a little bit higher along the cervix. And of course, the technique calls for burying the knot, slight difference from the next procedure, which again looks very similar, but the MacDonald cerclage, which did not require dissection, simply at a little junction slightly lower, putting your suture in a sort of a purse string fashion, and then again not burying the knot, and just simply tying it. Generally you see it here at 12 o'clock, and that's the technique that I favor, and most obstetricians, certainly in the United States now, are doing the McDonald as opposed to the Scherotka. Okay, now, in what setting are we using the cerclage? Well, we're all grew up and trained with kind of 4 areas. There's the elective cerclage, of course, when the history is such that it guides us to stitching as the appropriate treatment. More in the modern era, we would say. The second group is those where there are no historical factors, but just based on the ultrasound, we feel that a cerclage might be indicated, and we'll discuss that in more detail. The third group is the group where there is some kind of history to suggest they may benefit, but some uncertainty. But coupled with the ultrasound finding, they may meet certain criteria by which we feel this cerclage ought to be done. And then the fourth group, and sort of technically challenging and sort of exciting group, is those that simply present for a stitch because of the physical exam. Some have suggested we avoid these types of terms because it sort of leads to confusion, but you're going to see and read about in literature, people use the term commonly. We talk about the urgent cerclage, the emergent, the rescue cerclage, and so on. And many would say that we should stick to those that describes exactly the situation rather than these types of terms. So, but we can discuss that later if you wish. So what about the history? Is there anything new with the history? Well, nothing new really, but I think some point deserves some clarification regarding the history that you take from your patient in deciding who to have a cerclage. So the first indication that they thought might be beneficial is simply the woman who has history of a preterm delivery. However, all the randomized controlled trials trying to see if cerclage works in these patients found that it did not. So clearly, it's quite clear today that just simply a history of preterm delivery does not indicate the need for a cerclage. Now, you would see on the previous slide, the largest study of such was published from Britain, from the Royal College of Obstetrics and Gynecology. And when they re-looked at their data and did a sub-analysis, they found, aha, there is a subgroup of patients that may benefit. And the subgroup were women who had 3 or more preterm delivery or second trimester miscarriages. And it's in this group, of course, that there's benefit. So sometimes we have students or sometimes doctors sort of confused looking for more 3 or more mid-trimester losses. And that's incorrect because the diagnosis can be made on a single mid-trimester loss if all the characteristics suit incompetent cervix. So what aspects of history is important? Well, again, it's not just preterm delivery, but rather painless cervical dilation leading especially to a second trimester loss. Recognize it may occur with a single pregnancy, so the woman does not need to have 3 losses to have her cerclage if you feel, again, it fits perfectly the mold of incompetent cervix. However, obviously it would be confirmed, if you will, if this situation recurs in consecutive pregnancy. So again, the historical features, mid-trimester loss, painless, perhaps a history of cervical trauma if the woman had prior termination of pregnancy because of a fetal anomaly, and it here in Florida anyway was done, let's say, up to 23 weeks. I don't know what your various customs would be and laws, but in Florida, for example, you could terminate up to 23 weeks and 6 days. So that can be quite traumatic to the mother to have a termination done then, but sometimes there's a need for that. Again, some other things to think about is that the diagnosis, when we say painless, it is not excluded by mild symptoms or little pain, for example. So if you have contractions of short duration or cervical change inconsistent with the degree of contraction, for example, if the patient says, yes, it is not painless, I'm having a few cramps. He said, well, what are the cramps? Oh, they're just minor, like a very lightly of the cramps, and it's occasional. And on exam, you find that she's 4 cm dilated. Obviously, in that scenario, you would not consider the fact that she's having some cramping as painful. So indeed, this patient may very much fit the bill for cervical incompetence, despite the fact she's having some degree of pain or some cramping. Okay, so that's a few things about history. So the next group, as we said, the second group is, what about the patient who has history, not so certain, but ultrasound findings, again, would suggest maybe she may benefit. So let's take one example. Let's say the woman had a prior preterm delivery of uncertain cause. She, for instance, had contractions 2 hours before coming in. And by the time she came in with painful contractions after 2 hours, she was 4 cm dilated. Clearly, this would be a case that would be uncertain. What started first? Was it could she have an incompetent cervix that subsequently got an infection and started having contractions? Or was it simply, more commonly, the contractions leading to the cervical dilation? So in this type of patient, then, because the history is uncertain, then we would surveil the woman or keep watching the ultrasound length. And then at a certain threshold, we may decide to do a cerclage. And using this approach, it is found that many studies have shown you can avoid cerclage in many of these patients rather than doing it on everybody. And if you wait until the cervix is shortened and do a cerclage, then the outcome could be very similar than doing cerclage on everybody. So in that way, in these types of patients, you may avoid the cerclage in many who do not need it. Now, recognize this does not suggest avoiding elective cerclage altogether. For even those who feel, oh, don't worry, I'm great at ultrasound, I'll find it exactly when you need it. I don't think there's much point if the patient, as certain as you can be that she has incompetent cervix, let's say you had 10 patients who had a weak cervix, you scanned them all, and eventually you did the cerclage on 10, but you did it later. Well, I don't think that's necessarily a success because you haven't avoided the procedure. Meantime, you've done a lot more ultrasounds, a lot more worry of the patient, and the outcome is exactly the same. So if you think by history, the patient is a clear indication for cervical incompetence, you do not have to follow them by ultrasound. You could do your cerclage in the beginning, as many of you probably have done in the past. Now, what does the American College says about the patient then with a history of a preterm delivery and abnormal ultrasound finding? Well, this is their recommendation. If you had a prior preterm delivery less than 34 weeks and the cervical length is less than 1 inch or 2.5 cm before 24 weeks, then she becomes a candidate for cerclage. And they published this in 2014, and most of us has followed this quite strictly since then. What is the controversy today is that some have suggested that in this type of patient, that vaginal progesterone may be equally as efficacious. Now, the talk is really not on this aspect, it's primarily on cerclage, but I'll just mention that so that you're at least aware of that option of considering progesterone rather than a cerclage. But there's some caveats that you ought to know. So first with, again, prior preterm delivery and a short cervix, that they have never done any head-to-head non-randomized trial, no proper trial to prove which one is superior. It's really extraction of data from the published studies. And so it is with a grain of salt that we say there are equal options. but our college does say that we can offer the patient either or at this point in time. Now, the third group then is the woman who has no history. So first we have the woman who clearly has a history. We know what to do. Then we have the patient who has a history of questionable of incompetent cervix. And as we watch the cervix, we see the cervix getting shorter and we can offer her a cerclage. What about the third group of patient? That is no history, but she presents with a short cervix. So the first question is, how are we going to find these? Well, if we all did, or if you all do universal screening, that is, you check the cervical length at some point at 18 to 20 weeks, then you might find these patients. We're in some issues in this country because no major society in Britain or in the United States have endorsed universal screening. Many practitioners, including ourselves, are doing it, but again, it can't say that it's standard of care. So this short cervix then will be seen in somewhere between 1% and 3% of patients. So what do we do about it then when the patient has no history and we just happen to see the cervix is less than 1 inch? Well, in 2014, the American College of OBGYN said cerclage has not been associated with a significant reduction in preterm birth. So it used to be simple. You haven't had a preterm, we see the cervix short, we use progesterone, and we all sit back and hope. And one other thing to mention to you that this has been a change. With a short cervix, with no history on a short cervix, the recommendation used to be vaginal progesterone. In 2014, they used a threshold for progesterone at 20 millimeter. Subsequently, there have been other studies that said that threshold might be a bit too low. So the current recommendation as of this year has been to begin progesterone use when the cervix is 25 millimeter or less. So that's been a recent modification. Now, what about the cervix who's not at 2.5, but is shorter? Either you see her and it's much less than 2.5, then can we do anything different? So remember in 2014, they said no data to support it. The update then in 2021 is that maybe we ought to consider it. So very sort of limited data, but they found that in, again, examining the subgroup of patients where the cervix is not only less than 1 inch, but indeed less than 10 millimeter, that maybe there might be some benefit for doing a cerclage then. So again, very sort of ambiguous. They use the term in their publication that we may consider it and have a discussion with the patient, but rather than clearly endorsing it one way or the other. But we certainly have that discussion with the patient now, and many patients, of course, they're so nervous about that. Many just simply ask for the cerclage. The other part that I'll emphasize, and actually a couple of patients in the last 2 weeks we saw this in, if indeed the patient elects to not do a cerclage and you worry that the cervix is 10 millimeter or less, then I will caution you, please go through this exercise. That is, do an exam, because with the patient having an ultrasound and laying on her back, sometimes the cervix actually is open, but because she's laying on her back doing your ultrasound exam, the end of it may seem closed. And there have been published report on this, and I believe completely in the data published here, that if you examine these patients with just such a short cervix, that a third of them will actually be dilated. And so again, would be a candidate for cerclage based on the cervical dilation. So I caution you that when you get a cervix of that shortness of length. So now, the cervical length, what aspect I think you need to pay attention to in the ultrasound technique. As you do the ultrasound, you see the recommendation here. First, do it with an empty bladder. The patient obviously in the dorsal lithotomy position. You place the probe in the anterior fornix, but this is important that you withdraw the probe until the image is blurred, then reapply just enough pressure. Because with the probe itself, you can falsely squeeze the cervix closed, and I have a picture to demonstrate that. You will see in many reports, people talk about funneling and measuring aspects of the funneling of the cervix. And then you'll see also many people talk about fundal pressure. This has always bothered me because we really, when we say fundal pressure, how do we know about the strong guy or the weak guy, how much pressure we're putting, or the patient weighs 90 pounds versus 400 pounds, is the pressure we're pressing on the abdomen equal? So this has not withstood the test of time. So most people now find that these are not very helpful. So cervical funneling, what do we expect to see? Well, I use the example from our practice. Here you can see the head, of course, the amniotic fluid, and you see the cervix along here and the cervix on this posterior wall. Obviously, this shows the funneling here with the sac and the membranes protruding into the cervix, and you see the cervix quite short here. It happens to be about 6 millimeters. So this picture, actually, if you look, was just done a minute after. And you see this example, here's the probe. And this is one where the probe is putting too much pressure on the cervix that you just saw. And now if you apply too much pressure on the cervix itself, you squeeze it together. And now you have a cervical length of 1 inch. So that would be incorrect. That's that you're applying too much pressure on the cervix and make it look inaccurately lengthened. So I caution you about that when you're doing your cervical length. This was all the aspect of funneling. You see people used to measure the so-called funnel width, measure this distance, and then compare this distance with the closed portion. But again, this has pretty much gone by the wayside. And the important part now is just to identify how much of the cervix is closed. So again, cervical funneling, not much emphasis on that these days, just measure the portion that's closed. So again, here, this is a nice diagrammatic scheme of what you want to do. You want to simply measure the closed portion. This distance is not as important. When you're going to do a cerclage, it gives you an idea of the architecture of the cervix. So it's not wholly unimportant, but again, this closed portion is what's important in your assessment. Well, if you're going to monitor these patients by measuring the cervix, when do you start? Well, normally the most common time to start is around 16 weeks because very, very few patients are going to have a shortened cervix before 16. And of the few that are, you still don't generally lose much ground by waiting a couple of weeks, let's say before doing a cerclage. So the most common time to start is 16 weeks. How often do you do it? Well, again, most studies report doing it every 2 weeks. If we're right close to the threshold for an intervention, such as 25 to 29 millimeter, if the woman has a past history, then instead of every 2 weeks, we increase the surveillance weekly. And if there's no history where we say that your own personal threshold might be that 10 millimeter, and we see it just above 10, those patients as well, we increase the frequency to weekly. But every 2 weeks is pretty much a standard interval. Okay, the final group, the dilated cervix. So you're doing an ultrasound, very similar like the last patient. Here's the head, here's the cervix, but you see no measurable closed portion of cervix. So the cervix then will be dilated. So no closed portion of cervix here. So this is then you do your spectrum exam, and this is what you expect to see. Here you see the cervix, the lip, the anterior and posterior lip of the cervix, of course, and then you see the visible membrane. So this is what we hopefully don't see, but when we do, then these patients obviously will become candidates for cerclage. So again, this comes from 2014, and the American College of OB/GYN were very cautious in their recommendations. So let me just go through this sentence here. It says, however, emergency cerclage may be considered in such women in the absence of infection or labor. So you say, gee, if the woman is dilated, why are they so hesitant? And there are a few reasons for this. First, the precaution that it's a risky procedure at that time. You may rupture the membranes, and so the patient may blame you for leading to a loss. There's a risk of infection. There is sometimes a serious risk for maternal sepsis. So again, the caution, there are risks of doing the cerclage with a woman with a dilated cervix. The failure rate can be pretty high. Up to half of the patients, you will talk to them, put them through a procedure only for it to fail, so to speak, with them not having a healthy baby to take home. The other precaution is sometimes you may have a relative success, but let's say the woman had a problem at 17 weeks. You put in a cerclage and now it's successful, but only to about, let's say, 6 weeks. Now she has a 23-weeker that has a 50% chance of dying, and of those that survive has a 50% chance of long-term morbidity. So hence, these things have to be discussed and in detail, and that's why the American College was, again, used the term a little bit more cautiously, that it may be of benefit. And again, the last thing is that there's simply a lack of randomized studies. There's a hard group to study and have them enroll in a study to decide who should have a cerclage or not when they're so concerned about saving their pregnancy. Now, when we say a lack of randomized study, recognize there's lots of retrospective data. Here you see that says it works. Here you see one study saying, yes, it does in many patients when they're 1 cm dilated. Other use cervix that are 2 cm or more, again, showing in retrospectively that there's benefit. When they're even more dilated, 4 cm dilated, again, plenty of retrospective studies that suggest that the patient may benefit. But once again, I'll remind you that there's very limited data on randomized studies. It's just hard to get these patients, enroll them in a study, and do a proper randomized study, which is the ideal. This is often quoted as the only study, at least in the English literature, that where it was randomized, and we all like to lean on this as proof that it works, but look at the small numbers, 16 singletons, 7 twins. So again, limited data. So hence the precaution with the dilated cervix. Now, why does it fail? And why do we have to exercise so much caution? Well, the failure rate is high, and the question is why? And the obvious reason that most people feel is because many of these patients are actually infected, have a subclinical infection, and this is what leads to the high failure rate. So the question is, if we could find out who has an infection before we did it, then we'll save them having to go through a procedure. Sounds easy, but in fact is a very difficult proposition. And here's why. Well, we see that for infection, you see the risk is low if the cervix is just short. Makes sense. The cervix is short, membranes have not been exposed, so the anticipation is infection rate should be low. If, on the other hand, the cervix is dilated, and who knows how long it was dilated and how long the membranes were exposed to bacteria, then the infection rate can be much higher. And here, one report suggesting that if the cervix is more than 2 cm, then half the patients will have subclinical infection. What is the importance of this subclinical infection? Here's one of many studies in literature, but these physicians reported that if you do a cerclage and they're more than 2 cm dilated, and they happen to use LDH level and glucose level to try to figure out who was infected or not, and they reported that if there were no infection, here they had 11 of 11 successful. If they had no amniocentesis, meaning that they didn't know who was infected or not, that they only had 2 of 11 survivors. And then if they decided not to do the cerclage because the amniocentesis suggested infection, then all of these patients went on to losses, and they claim that this was all within 2 or 3 weeks. So again, they're suggesting that a determination of subclinical infection may be important in determining who may benefit for cerclage or who may not. So it sounds like a reasonable thing to do, to offer amniocentesis to all these patients who present with dilated cervix. But we have lots of question marks. First, there are many sort of criteria that people have come up with, or guidelines to make the diagnosis of infection. So do we use glucose? Do you use the number of white cells? Do we wait on a gram stain? Do we wait on a culture? What do our lab do for culture? And then the more recent addition to this is inflammatory markers, interleukin, MMP, and can these be used to determine infection? So there is a lack of a standard criteria for what to use. So you'll see that these factors vary in their ability to determine infection. So everybody's searching for a threshold that they would use in their individual hospital. So what are the clinical problems? Well, we have the issue of what is the definition of subclinical? Well, we know the gold standard is culture, but if the woman is sitting there with a dilated cervix, then we don't want to wait in a culture. So again, some debate about what we ought to use. Who should we do an amniocentesis on? Do we do it at 2 or more? If it's just short, should we? So again, most would say reserve it at least for the woman who has advanced dilation. But should it be 2? Should it be 3? That's a matter of debate. Well, what if we do find some evidence of infection or subclinical infection by some criteria? What do we tell the patient? Do we simply tell her that the benefit or the probability of success is much lower, or is it 0? Because if we say, well, it might be 50%, but if you have inflammation, 10%, what does that mean? Does it mean that the woman then will not have a cerclage, or do we still offer it as long as she knows that the failure rate is high? So again, the way to use amnio is just very debatable. And currently in the United States, most people are not offering amniocentesis before cerclage, even when the woman is dilated. So again, the problem, just to summarize, is lack of randomized studies and different criteria for the diagnosis. So the amniocentesis, consider it if the cervix is dilated. You recognize that the criteria for infection remains still somewhat controversial, and at least explain to the patient the purpose would be perhaps to give you information, maybe avoid this unnecessary surgery. Maybe her biggest fear is having surgery. So she may feel better, if you will, knowing that she has a high chance of failure as she chooses not to have surgery. Another recent big problem we have is that some people have reported, and this has never been felt to be effective, but there are some who suggest that if they have subclinical infection, you can actually treat with a 2-week course of antibiotic with resolution of that infection. But I think we're going to need a a few more years before that's the proven or disproven. One other feature here, sometimes you see some debris or sludge within the fluid, and there's a question mark of whether that means infection or not. It's debatable. Some say yes, some say no. So we pay attention to it and use it in our discussion with the patient. The final aspect of the talk is some aspect about technique. So if the woman is dilated and the membranes are bulging and sometimes beyond the cervix, we simply can't put a stitch here and squeeze down on the sac. And the most common method that, in my hands anyway, is this again, use of a Foley balloon. So if the woman is dilated, you use the Foley balloon to reduce the membrane. And just to cover this aspect, if you use a 30 cc balloon, the diameter of the balloon will ultimately fully expanded be about 4 cm. So if the woman is about 4 or 5 cm dilated, usually you can get the membrane back. If they're much beyond 5 cm, usually I've never been able to get the membranes back when they're more than that. So if the woman is 8 cm dilated, I usually tell them that no, then I can't offer a cerclage, not in my hands anyway. And this is what we hope to achieve, of course, putting the membranes back and doing the cerclage. Finally, and I guess this Baptists are becoming experts at this, the abdominal cerclage. I know most of us, I personally have never done one, and we know there are very few places for it. But certainly if there had been a failed cerclage, then the patient becomes a candidate. And the new thing, of course, is the robotic technique rather than doing an open laparotomy, and that probably has revolutionized this whole aspect of abdominal cerclage. And of course, the robotic technique, enhanced visualization, is key in the dexterity of the robot. And it's been doing it for about 10 years now. There have been several cases here, not a lot because there are just not a lot of cases, but they've been pretty experienced at it here at the institution. Previously, we didn't have much data, and I was always skeptical about the need of it. But recently, there was a tremendous study that came out of Britain that they actually studied women who had failed cerclages. You see, the number is quite large, 133 patients, and they all had failed cerclages. That is, they still delivered before the second trimester. They excluded the failed cerclage for the who did it because of dilated cervix, just to exclude infection, hopefully. And they randomized the treatment to transabdominal, the Scherotka being a higher vaginal stitch, and then the McDonald, which is a little bit lower, but generally equal. And they looked at to see how many patients were able to get beyond 32 weeks. And the data was quite clear that in these situations, that the abdominal was the best, much lower rate of failure, and that the Scherotka and McDonald were about equal in that a third of them will simply fail in a woman who has a previous failed cerclage. So again, it seemed quite clear in that woman who had a cerclage and still had a loss before 28 weeks, she's better off having an abdominal cerclage. And this can be done either in pregnancy or pre-pregnancy. So again, the technique just shows the procedure being done much higher level than the McDonald or Scherotka. When do we remove the cerclage? If the membrane ruptures, ACOG doesn't really come out with any clear direction. For me, I simply leave the cerclage in place. And unless there's infection, we keep going. So here's a straightforward algorithm that just to summarize, if there's a history and it's a classic painless loss, either singly or repetitively, then go ahead and do your cerclage. If you're uncertain, there's a preterm delivery, but you're not sure what the cause, then you can begin surveillance every 2 weeks. If it's greater than an inch, 2.5 cm, you do nothing. If it's less than 2.5, you can either offer stitch or progesterone. And if it gets progressively shorter, then certainly the patient then becomes a candidate for cerclage. If you do universal screening, or if you screen and you just happen to notice a short cervix, very similar. So if the cervix is short but greater than an inch, nothing needs to be done. If it's less than an inch, then use progesterone. And similarly, if it's continues to shorten and now less than 10 millimeter, then they can be offered progesterone or cerclage. Okay, so to summarize then, hopefully then we will learn to pay attention to the specifics of the historical factors. We can understand the issues regarding management of the short and dilated cervix. We can counsel on the role of amniocentesis with more confidence on the pros and cons of it. And we understand exactly, without hesitation, which patient would be a candidate for the abdominal cerclage. Okay, that's my last slide. So I thank you for your attention, and I'll turn it over to Dr. Hakim.
Thank you so much, Dr. Lai. What very difficult type of determination you have to make, especially for this very delicate conditions that the woman presents, especially during the very early trimesters of pregnancy. In order for us to determine the risk factors that potentially will put these ladies at risk of miscarriage, what should we do in anticipation for during our well-woman check? What do we need to keep in mind in order for us to instruct the woman that potentially she would have an issue with her cervix? How can we identify that as physicians?
So there are two ways. The most common, of course, unfortunately, most women having their first loss don't have a risk factor. But if they did have a prior loss, of course, that's a huge indicator. The other things would be surgical. You know, the woman sometimes may have, well, several terminations of pregnancy. So we normally say one termination, no, but if she has several, especially later in pregnancy, that's a clue. If she has had many diagnostic or surgical procedures on the cervix or conization of the cervix, then that would be additional clues.
I see. And you also mentioned something extremely important, and it's the fact that if the membranes are protruding beyond your assistant device with the Foley to push back, is there where you actually say, you know what, I'm not going to be able to do cerclage, but maybe an abdominal approach through robotic will be perhaps an indication?
No, I've never seen that done. The robotic is really done when they're not dilated. It's not a certain emergency procedure. So it's done basically for a history of a failed cerclage rather than a dilated cervix. So we have to wait and see if it can be dual. Obviously, if they operate from above, they can't push the membrane back. So it's a question of whether you could do it from below while they're operating from above. So right now, I would say no. There's no indication of abdominal in an emergency.
So is that considered a failed pregnancy?
Yeah.
Oh,
and then we throw our hands up and try to be compassionate, but there's a point there that it's beyond our help, as we know now.
And how far do you carry the pregnancy with cerclage?
So very good question. So in terms of timing, we don't do cerclage beyond 23, 24 weeks, but partly because we have, you know, in our system, level 3 nursery. So just to throw some numbers at you, even at 24 weeks, the majority of babies will survive in our hands at this hospital, you know, in our system. but there are many, certainly in rural parts, that at 24 weeks, the survivability is 0. So, that's, you leave the cerclage as long as you can. You leave it into 37 weeks. But it brings up the other question. If you don't have a very good nursery, but the cerclage, at least you could do that, then perhaps you do a cerclage even later than we would hear. Because knowing your nursery is not very good, you may say, gee, at 25 weeks, even if the baby delivered now may have no chance, I am going to do a cerclage. We don't hear because we have such an excellent nursery. But that's a good question in terms of how late would you do it? And then the final one, when do you leave it until? Well, if it's successful, we leave it until 37 weeks and remove it then.
Right, and you're absolutely right, and we are extremely fortunate to have here South Miami Hospital as one of the centers of excellence for maternal and fetal monitoring. As a matter of fact, is one of the very, very few facilities in the nation that offers these type of services for premature babies. We see that a lot. Dr. Paris and obviously works directly with your team in monitor these particular babies that potentially will be delivered kind of early in stages. You also mentioned in the presentation that robotic is one of the approaches, and obviously I alluded to that as well. Just for the audience to know, we are one of the centers of excellence in robotic surgery. Therefore, all these incredible new approaches to all different kinds of abdominal techniques are done robotically with the latest robots in our system. And we're proud to say that we have about 25 of them currently in action. So Dr. Lai and his team obviously will be able to manage either way, either through cerclage, through the approach that he spoke about, or perhaps more advanced through robotic or abdominal approach. We have a couple of questions that I would like to get to, Dr. Lai, before I let you go. I know I've robbed enough of your time today, but Dr. Fermin is asking, at what stage of pregnancy do symptoms begin to appear?
So normally, most patients, as you know, with true incompetence have no symptoms until closer to around 20 weeks. And, that's when they start saying a pressure or mucoid discharge. When the patient tells me she has lost the pregnancy, let's say at 15 weeks, I almost feel that it cannot be incompetent. But we start the monitoring at 16 weeks. So probably more people would feel that it's beyond 16 weeks when they would show any signs at all, whether it be pressure, mucoid discharge, that kind of thing.
Great. Is there a relation with assisted reproduction and incompetent cervix?
Yes and no. That's debatable, but they oftentimes do procedures and they use instruments to look into the uterine cavity. And yes, some people have reported a link, but at least it's a very weak link. We don't want, so no, I would say generally not, but we certainly have seen those types of patients, and we monitor the cervix very carefully in women who have had IVF just because of that potential.
Right. How was the cervix measurement done prior to the use of ultrasound, and how accurate was the measurement then?
Yes, so the obstetrician, they did a pretty good job. The ultrasound, I tell patients this way, that the cervix in two halves. There's a half that I can examine from below and that I know about, and they're in the top half that ultrasound will determine the length. The problem, of course, with incompetent cervix, it opens top down, not bottom up. So we're often late in the process of finding when they're dilated. But yes, we measure the bottom half, and the ultrasound measures the top half. So.
What is the, yeah, no, I mean, you got to think about in the early 900s and 1900s, how they did it. And it's like, wow. And I mean, amazingly, the physicians would say, you know what, I can fix that with the cerclage.
Exactly. So we went to Dr. Scherotka, said, 4 babies, all losses, I think I can help you.
Yeah, easy. Few stitches here and there, and you're done. Making the light of the situation. What is the more adequate recommendation if we have a patient with 11 weeks of gestation and we find the short cervix, for example, 20 millimeters in association with a positive elastography, and cervical consistency index of 54%.
Yes. So we're not, right now, again, we do it simplistically. There are probably more functional abnormalities, but right now it's all based on anatomic length, you know. But people are certainly doing work trying to figure out other aspects of looking at the strength of the cervix, but that's far away from being used clinically. So right now it's confined to simply measuring the length. So really, if it's less than an inch and she has a history, then you can consider cerclage. So the functional aspect is important too. We just don't know how to measure that yet.
Can you briefly talk about the twin gestation? And also, would you ever consider placing a cerclage after a loss of a twin A in a dyschronic diamniotic twin present with clinical pictures of incompetent cervix, no signs of infection?
Yes, I skipped one of the slides there and actually was on twins. Everything in twins is controversial. Nothing is concrete about this role in cerclage. So if certainly for twins, if the woman has a history of incompetent cervix and you have twins, yes, that's an indication, because if you're going to do it for one, you'd most certainly do it for two if her history supports it. But just on ultrasound finding, for example, no, we don't know how to use cerclage if it's indicated. And recently they published a study which the American College mentioned a few months ago in their publication, Preventing Preterm. And it says this, and this is new as well, that if the woman is dilated with twins, that we can consider. Before we used to say there's no data to support it. Now, if you're dilated with twins, we certainly could consider. And actually, we've done a couple that we're very proud of at in our system, where everybody say, hey, what are you doing? They're going to be lost. And, you know, we all keep those, of course, remember those successes. So we're a believer that if they're dilated with twins, and of course, no sign of any other problems, they are candidate for cerclage. And so the American College allows you for that consideration now, and that's new as well. Yeah.
Dr. Alan Lyons states, I have seen few cases of amnionitis, bacteria, and also fungal infections that in these cases of elective cerclage. Would you recommend the use of any prophylactic vaginal antibiotics or antifungal creams throughout the pregnancy?
We don't know about fungal, but with the dilated cervix, if with dilated cervix, there have been several studies now that have included antibiotic. We just don't have any side by side with those that don't. But most of us now, if they're dilated, will use antibiotics. We don't have, in fact, one of the regimen you see there, they had flagella as well. But we haven't decided whether that's necessary in the dilated cervix yet. But certainly antibiotics would be used, yes.
Okay. And the final question is from Dr. Brooks, and she is asking, what are your thoughts on the McDonald approach?
I love that procedure. It's so simple. When the patients come all nervous, I just say, don't worry, I'll be done in 10 minutes. So I find that comforting. And almost certainly sometimes if it's such a wonderful procedure that in a few minutes you could do something that obviously can be such a savior for the baby. So that's why I love that procedure, and I love the whole aspect of teaching about cervical insufficiency. So I'm a big fan of McDonald, simple, effective, and a big fan of that technique.
And as many physicians are as well. Now, Dr. Lai, what is the percentage of these cases that you see in obstetrics that come with these incompetent cervix out of the bunch that you see in a year? What would be the percentage that you can actually say have incompetent cervix?
No, you should see that at least amenable to cerclage, no more than about 1%. I mean, if you have a population like a lot of multiples where damage to cervix can occur with labor, it might be higher, but about 1% you can expect to run into that. We happen to see a lot here just because they're very, fewer and fewer doctors are doing it because they don't encounter it as an individual And so we, a lot of patients just come into our system for that. So we see a fair amount here, but the regular practicing OBGYN should not see a lot in their practices individually.
Well, you know what, Dr. Lai, we're very fortunate to have you in our team and also in our system, health system, simply because you have given at least some hope to many of the women that come with these type of problems. Thank you once again for doing this for us and sharing your knowledge and for all your expertise. We really thank you for everything that you're doing. So our time is already 5 o'clock, so our time is done. And I would like to thank you once again, Dr. Lai, on behalf of our international team for your great presentation, and to all of you for participating and attending. As usual, if you have additional questions about today's presentation, please feel free to email us at bhiwebinars@baptisthealth.net. We'll make sure to get that to Dr. Lai so he could respond, and we will forward those to you. We look forward to seeing you at our next Women and Infants lecture series scheduled for November 10th, 2021. And meanwhile, please stay safe, get vaccinated, and we shall see you again. Thank you so much, Dr. Lai. Have a great afternoon.
Thanks, Dr. Ian. Thank you very much.